Yesterday was the start of the NFL football season, and not that. College football is going on, high school football, It's all happening. Mm-hmm. And Dr. Jeff Mason here from Everett Bone and Joint, orthopedic surgeon.
But he doesn't work on hearts.
He can take a continuing education course on the weekend and be with you next
In
next
orthopedics,
month.
we say the heart is only there to pump blood to the bones.
Right. I like that. Quote, write that down. That's a good quote. So here we go. It's injury time of year. We have the NFL, again, college. Just talk about college. We were watching, at least I was watching the Notre Dame football game on Saturday. Their quarterback, Malik Zaire, gets tackled from behind, rolls his ankle. You can see on TV, this is not just a sprain. And then it comes out, he fractured his ankle. So I assume he probably fractured most likely his fibula, but maybe the tibia. Tell us about ankle fractures.
Well, it's actually interesting. I did not see the footage you're referring to, but most ankle injuries happen when the foot inverts. And what do I mean by that is the sole of your foot goes in. It's the classic, gee, I rolled my ankle playing sports or running on uneven ground. With injuries such as we're describing, football, people are cutting, getting hit from odd angles, you start seeing more different fracture patterns where all of a sudden the foot and ankle are shoved in these less typical directions. But fractures are important because it's a joint that only allows motion in two directions, just up and down as it were. And just how well ankles work for your whole life is astonishing because it's a small joint. It withstands a gigantic amount of force. And so when there are fractures there, we take great pains to try to make things literally perfect because, what would be okay in another joint, in another area in the ankle won't be okay because the forces that joint has to withstand are so high that you're really trying to strive to make them perfect when you fix them.
Yeah, when you describe the ankle joint, I really appreciate how you described it because we call it a mortise, a joint. It's so precise in the way it works. Now, with Malik, when you looked at the replay, you could tell by the replay this is not just a sprain because it was an aggressive roll, an inversion.
Right.
So most likely that talus or that ankle bone is rolling out there. Does it normally fracture the end of that fibula and then come back and get the tibia, or is it what bone are we concerned about there?
Well, both of them, because normally what happens in patterns like this, and he may or may not have had a dislocation at the same time, it's certainly possible, but the forces, including the talus, will actually go out and it will knock off the bone, the medial bone, as it twists underneath the ankle joint. The inside bone, part of the tibia, the medial malleolus, will get knocked off, and then the outer bone is sometimes not directly impacted so much, but is subjected to this force, so that it'll have a spiral fracture, and you worry about what soft tissues are injured at the same time.
And as a surgeon, when you're looking at that, and you have to think about repair. If you're talking about the tibia versus fibula, what are you deciding on there?
Well, what you're looking for is when you reduced if there's a dislocation or fracture, and you manipulate it, put it back in some kind of position. And then you look at x-rays and you say, well, how good is this? And what you're looking for in these situations is for it to be very, very close to perfect, or it's not acceptable. And so if either the inside or the outside part of the fracture is off by more than just 1 or 2 millimeters, you say this has to be fixed. Or if you say, gee, the two fractures are in good position, but the entire joint is widened where the relationship of the tibia and the fibula are not proper, then you say, well, we have to fix it even if they're only soft tissue injuries.
And when you talk about that, which we call the syndesmotic joint there,
yes,
between the tissue that connects the fibula and the tibia, that connective tissue sometimes rips apart and gets torn in the fracture dislocation.
Yes.
And as a surgeon, are you wanting to put that back together? Are you going to put a screw or sometimes stabilize those two bones to hold them together?
Yeah, there are a lot of ways to do it, but what you're trying to do is recreate the proper relationships in terms of geometry of those two bones and then hold it in place. And traditionally we've done it with screws. But there are also other devices where you drill holes and you use suture material or little metal clips and such to do it. But they're all trying to achieve the same thing, where the two bones are held in the proper relationship, and that will allow the soft tissues to heal. Those particular soft tissues have a very good healing potential, and if you put them where they're supposed to be and leave them be, in the vast majority of cases they will heal right up, though it does take a significant period of time.
In the fracture, when you're talking about viewing the fracture on X-ray, I mean, you're determining if it's the end of the bones, we call that the malleoli.
Yes.
If it's somewhere in the shaft, it kind of changes how you repair it or how much hardware, particularly in the tibia, because it's a pretty large bone. And do you ever have to put a rod in that tibia?
Well, yeah. If you that immediately becomes something that you call something different from an ankle fracture. What we call an ankle fracture involves the big bony prominences on the inside and the outside. Once the fracture actually gets into what we call the plafond, or the weight-bearing part of the tibia, it's a whole different kettle of fish, much more serious injury yet, and those are put together in a very different way, and it's a much more serious injury, even beyond ankle.
Will you do a different surgery on Shannon O'Kelly than you will on the quarterback for the Notre Dame Fighting Irish?
No.
Okay.
Yeah, I mean, that's a good question, though, Tom, because, I mean, when you look at stabilizing this athlete that's going to return, because he'll be back next year. He's out for the season, but he'll be back next year.
Right, but it's a very good question. But what it gets down to is even normal use of the ankle is demanding enough just for someone who's engaging in moderate daily activities that you still have to try to make them perfect, or you will have problems.
And you talked about, as an orthopedic surgeon, the heart is what pumps blood to the bones. I mean, that's something you're assessing. And that smaller bone, that fibula on the outside, which is the small shaft bone, versus the tibia, which is a large shaft bone, which one has more concern when it comes to blood supply?
Both of those fractures heal pretty reliably. The ends of bones are typically areas where the blood supply is quite high, and so if you have things in good position, any fracture can go on to a non-union, but we don't see it very commonly in ankle fractures at all. Once you start going farther up the tibial shaft, then you start seeing those issues sometimes where fractures don't want to heal, and you have delayed unions or non-unions and that sort of thing that you have to figure out how to take care of.
Can we switch to another injury?
Absolutely.
Wide receiver Des Bryant to the Cowboys last night. Broken fifth metatarsal.
Okay.
Is that along the top of your foot? Is that what that is?
That is the very outside of your foot. And what that injury is it's sort of like a bony version of an ankle sprain. And what I mean by that is when you have an inversion injury, which is what would cause this, the same sort of thing, it all has to do with the exact position of the foot, the exact way the forces are transmitted through the injury. Some people with that injury would sprain their ankle badly or possibly even dislocate their ankle or get an ankle fracture. In his case, what has happened is one of the tendons that attaches to the end of that fifth metatarsal, that bone on the outside of your foot, was stronger than the bone, and the tendon has pulled the bone off of the rest of the bone.
That's what we call an avulsion.
Exactly.
And then, but he's out 4 to 6 weeks, so that is an easier fix than a fractured ankle dislocation.
Yeah, they tend to be very irritating to put up with because they don't really hurt that much, and they heal pretty reliably. And so people are often in the situation where it doesn't feel that bad, and they want to progress their activities sooner than they should, and next thing you know, you will create a non-union. So, he'll be happier psychologically if it hurt a lot more, but I wouldn't be surprised if a week and a half from now he was saying, so my foot hurts a little bit, why can't I do this, why can't I do that? But if he does, it will be a problem.
It's interesting.
He went out earlier in the game to get fluids because he was dehydrated. Would that have anything to do with hurting his foot?
No, I wouldn't automatically think so, no.
Okay.
It was a fairly benign play. If you watched it on replay, he went down, and probably just the torque and the twist kind of caused stress in that fifth metatarsal, and like Dr. Mason was saying, just pulled that and involves that tendon, and that fracture occurred.
Yes.
It's amazing sometimes. I mean, the little things when you watch. I mean, just like there was a defensive back for the New York Jets, tore his ACL yesterday, non-contact. ACL tears a lot of times are deceleration type injuries.
Oh yeah, I tell people all the time that even though when we're given sports footage about ACL tears, it's often something like Adrian Peterson, which was this dramatic injury where his foot was planted and he was hit. But the majority of them are non-contact injuries. That's how Jordy Nelson tore his. He, came to his feet as he caught a ball and went to accelerate and then just blew it up.
Right. Let me ask a question. I mean, I'm remembering back when I was a kid, and it seemed like there was always someone in the neighborhood that had a ankle fracture or a broken leg or something like that, but they always cast them. I don't ever recall anybody ever having surgery with a metal plate or a rod or screws or wires or whatever. What's changed in orthopedics now with the decision Why don't you just cast some fractures and do metal, hardware, and surgical intervention?
Well, the bar is higher. We realize that if they're not in really good position, we have a higher incidence of people who go on to earlier arthritic change. And so there are certain people, I mean, it's not uncommon for me to see ankle fractures in the office where I just say, you'll be fine, we're wrapping it up, you're going to be okay, especially in people who are older and less active. But even then, these are fractures which on x-ray you look at it and you say, well, there's a little crack here, it might be up by a millimeter, it's in virtually perfect position, then you leave them alone. But the ones that are out of place, we fix more aggressively because it's also a way of getting the problem behind you. Because if you reduce an ankle fracture, it's pretty easy for those pieces to move, and you have the phenomenon where you put it in place, it moves a little bit, it's no longer good, then you put it in place again. And every time you do that, it's a pretty uncomfortable procedure for the patient, unless you're taking them to the operating room and doing an anesthetic, and you're saying, well, wait, why don't I just fix the problem once instead of fixing it 3 times?
And when did the external fixation with hardware become popular?
It really, this is something that's become more and more popular literally in the second half of the 20th century. It was done before then, but much less commonly. We really had to get control and treatment of postoperative infections under control before that became an option, because otherwise, let's say you took someone with an ankle fracture, you operated on them, they got a bad infection, and next thing you know, they had an amputation. Well, until antibiotics became prevalent, that was a significant problem. Now, we don't even routinely use antibiotics for all surgeries, or another way to put it is we routinely do, but the bar for not doing it is quite low. But that being said, we've been attending to operating room sterility for it's a constant project in medicine. Every time you set a new standard, you sort of say, how can we improve on that now? It never ends. And so this is one of the reasons why operative fixation has become more popular, is because it's more effective, it's safer, and you have a better chance of getting a better result.
And with hardware, it's hard sometimes for patients to understand that sometimes that hardware stays in there. I mean, you're not generally going to go in and remove the hardware for these ankle fractures unless there's a problem.
Right. I tell people we often take them out for ankle fractures, and I tell patients there are several reasons we do it. One reason is because they can be irritating. Sometimes the ankle does not have a ton of soft tissue cover, so people say, oh, I can feel these screws when I put my boots on. You take them out. Other times people say, gee, I know I can feel them, and I don't really know why, but I know they're there. But other people will just freely admit, they say, I don't even know they're there, except psychologically it's driving me crazy that I have the stainless steel on my ankle and I want it out.
And it sets off the alarm at the airport too?
It can, except the body is pretty good at screening that stuff, so we'll even occasionally see people with total joints who don't set it off, although you expect that it will.
And when you're fixing...
We got to go.
You got to wrap up?
Yeah.
Whoa, okay. We'll have to have Dr. Mason back. Definitely continue to talk about these injuries. It's football season.
We'll see a lot of them.
Yeah, absolutely. Thank you so much, Dr. Mason, Everett Bone and Joint.